Hello, everyone. Thank you for joining the Spina Bifida Association's Clinician Information Session, Bowel Management in Adults with Spina Bifida. Our presenters tonight are Joy Kerr, Children's Hospital of Philadelphia, and Mary Ellen Kelly, Duke University School of Nursing. Mary Ellen and Joy were part of the team of nurses, parents, and adults who developed the Lifespan Bowel Management Protocol, which can be found on SBA's website. My name is Judy Thibodeau, and I'm a member of SBA staff. For this session, I'm joined by my colleague, Juanita Panliner, SBA's National Resource Manager. Joining us for this session, and Mary Ellen, it's yours.
All right. Thank you, everybody, for hopping on tonight. And for those who watch this another time, thanks for taking the time to do so. Joy and I are really excited to be here to talk about poop. It's our favorite topic. And additionally, it's nice to be with clinicians because we're hoping to learn some tips and tricks that you guys are all using. And hopefully you can learn something from us as well. I think caring for adult neurogenic bowel is definitely an art form that we are all trying to perfect. So it's great to have this platform. So to kick us off, if you haven't, I will stall on this slide for a moment so that you can scan the QR code. That will take you to the Lifespan Bowel Management page that is housed on the SBA website all the time if you need it in the future. We ask for your name, email, and I think maybe your institution when you download this. It's just because we are in the works of updating it. And this way, as soon as we update it, you can get a blast that there is a new version. We will not utilize your information in other ways, but we are going to reference this protocol throughout the talk tonight. And hopefully you will reference it many times as you are caring for our patients. So this protocol was developed from 2019 to 2021 from this group here of wonderful providers, as well as lived experience from Adam and Heather, who is a parent of a child with spina bifida, and Colleen as well. So it was really a team effort, and Joy and myself are just representing the team for this. The protocol was also reviewed by the PAC, as well as two GI specialists at other institutions. So the ultimate goal of a bowel program, it's really the same for adults as it is with children. It's really trying to achieve bowel continence as well as independence to the best that we can. We know that with adults in particular, you might be less reliant on caregivers or parents. So it's also balancing kind of the capability of that individual and what their personal goals are. So there are some adults who would prefer to be a little less continent, but be fully independent, versus the reverse. Somebody who's like, nope, I want to be completely independent, or all independent, less continent. So then I will be okay having a care partner assist me with my bowel program if I can be fully continent. So having those conversations, knowing what their goals are, it might even just be shortening the amount of time that they're spending on their bowel program. I know we see a lot of adults at Duke right now who are coming from institutions and they're spending 3+ hours on a program. So their goal is to shorten the time. So figuring out what those goals are, and then we'll work together to achieve them. The main objectives we have for you guys tonight is what was shared before. But again, we're going to share what we believe are the current best practices and also some techniques to help adults who maybe are new to having a bowel program or have a very faulty bowel program currently. We also want to review some new changes to insurance for bowel management devices and discuss some of those common adult topics: independence, pregnancy, and sexuality. So a few key points, again, caring for our adult community. Super important that we are just, having those frank conversations with the adults themselves and with anybody who's living with them or helping to provide their care. And of course, yourselves as a clinician. So really setting those expectations, especially if this is a new bowel program or you're really changing someone's bowel program, it's nice to say, hey, this is going to take 3 months, 6 months, whatever you think it's going to take. Giving those baby steps in between, finding a time in their schedule where, hey, we're going to be tweaking things here in the beginning. It might get messy. Things might get worse before they get better. We need to find an appropriate time where they're navigating family and work and everything else, where that's going to be sort of accepted. So really having frank, honest conversations. You don't want to break trust there. And I guess also, especially if you're new into an adult clinic, or maybe you're starting this kind of care in an adult clinic, realizing that a lot of adults are coming in with potentially no bowel program and without a lot of information about the options out there. So realizing you may have to really step it back to talk about it. We also think it's important as clinicians that we don't just talk about this once. Obviously, you guys are all here, so I think this is a committed crowd, but it's really at every visit kind of checking in. Hey, how are the bowels going? What's going well? What's not? When are you having issues? And really making sure we're having this as part of our yearly check-ins. Also being frank about, again, how bowel programs or a lack of a bowel program can really interfere with an individual's sexuality or sexual function. And that might be where you can get some buy-in from patients who are slightly resistant. I don't know, but something to potentially have a conversation about. Taking it back, when you're first seeing an adult with spina bifida who you're discussing a bowel management program and they want to do a bowel management program, it's important to really do a good physical exam so you have an idea of where they are. So again, this is a group of clinicians. You guys all know how to do all of these things, but just because we know how doesn't mean we always do. So we have this kind of extensive list here to just sort of remind us best practice and doing a good physical exam that is going to be able to help you inform what bowel programs may work, right? So just simple things like percussing and auscultating the bowels. You'll get an idea of kind of how fast is that motility potentially, how constipated is that individual. Palpation, same idea. Of course, there may be less sensation, so you might not get as much tenderness or discomfort if you're palpating, but I'm sure we have all palpated large stool masses before. That can be really handy intel for you. Of course, when you're looking at the bottom, you can see if there's any anal fissures, any external hemorrhoids, are there skin issues? All of that's going to let you know what you need to do or what you can't do, right? If someone has huge hemorrhoids and things, I might not be putting a lot of per rectum interventions right away. It's also going to be a clue that they might have some serious constipation or they spend too long in their toileting routine. Dermatitis of some sort, you're going to need to use some barrier creams off the bat, right? Anal fissures, also a clue about severe constipation history. When you're examining the anal sphincter, same idea. We're going to be kind of looking at how it functions. That function is going to tell us a lot about what kind of interventions we can potentially use. So if somebody has a little bit more of an intact sensory or motor development, that anal wink, and they actually have some tone there, they might be somebody who could be successful with digital rectal stimulation or suppositories or something where you need to actually hold it in your rectum without an assistant. Glycerin suppository is not going to do much for somebody who has a wide open, patulous anus. It's going to come right back out. So knowing that in advance is going to just allow you to kind of skip around a bit in your interventions. And finally, a digital rectal exam. Not always necessary, but sometimes you do need to do this, and it will kind of give you some intel again regarding how distended is that rectal vault, and also is there a fecal mass right there? Because some of these interventions, albeit we'll argue all of them, you should probably do a clean out beforehand to make sure that you're going to kind of push for success. But you could always do a quick little rectal exam to make sure, did they really do a good clean out? Are we ready to start a different intervention? And finally, KUBs. This might be a hot topic for some, but we will just state what the consensus guidelines are. So routine use of a KUB for constipation is not recommended as consensus guidelines from the European Society and the North American Society of GI. Really, this is just because the way that you grade for constipation has never been well validated. So there's really just a difficult, or as it says there, is poor sensitivity and specificity with all the different scoring systems for a KUB. Now, that said, it's not saying you can't use them, but just being aware of that this shouldn't be a routine automatic thing, but you're using it carefully and with consideration for a specific reason.
Can I add one other thing here?
Yes.
I really feel like one of the things, it really leads into the bowel clean out. If I have a patient who's really soiling, I may get an x-ray, and if I note a large stool burden and I then have them do a clean out, or if I just palpate a lot of stool and I say, you're going to do a clean out, I may do a KUB after, like within, I usually say you're going to do your regular clean out with Miralax, but then you're going to do your regular enema the next morning. And then within 2 hours, I may get a KUB to check and see what that stool burden looks like comparatively. So it's just something that I use sometimes as a tool. But let's talk about cleanouts. So we always say that, a good clean out is important. I would say that patients with spina bifida, we know, have very different transit times than you and I do. And so if patients are already on some type of an enema program, I don't just do a full oral clean out with either Miralax or mag citrate. I also accompany it with a regular enema from below. And then I do that the night before, the morning of, we do our oral clean out all day, and we do another enema at night. And that's really helpful for kids with patients with spina bifida in general, because their transit time is very slow. If you only use oral medications, it could take days for it to work. And so that is something that is really important to have, to consider, is that it can really be a problem for some patients that it's not happening the day that they think, they've set this time off, especially if people are taking off from work. But it could be days later that it actually kicks in. And some patients who have very severe obstipation may need to go into the hospital and have a real clean out done, or go to surgery to have a disimpaction. So okay.
Sorry.
Okay. So for a next slide, do I have control?
No, I do. I got it though.
Okay. I'm so sorry. So setting people up for success, a full clean out we would do when people are starting a program or if they're very constipated. A partial clean out is for people who have some mild constipation, they're soiling, and we want to do a reset. We might do extra enemas where we do a morning, night instead of a nightly enema. Or we might add some extra ingredients like some glycerin or some Castile soap. Sometimes even just baby shampoo is enough. And then inpatient, we talked about that. Having a supportive caregiver, friend, significant other who can support your patient through this journey is really critical, because some of these things patients really struggle to do independently. And then ensuring that the bathroom is set up for success and that you have the time and privacy needed to complete the irrigation or the enema, and then allow the time to evacuate. That's also going to be very important. Next slide. So just talking about caregivers, burnout is very high. If somebody is not independent in their bowel management and they require a lot of help, then if there's only one person who knows how to help them, the burnout's high for this. And they never feel like they can go on vacation or do something without that person because they need to take care of them. So it's important to train more than one person to help them and be, there and available for them, and alter programs as needed. And then, of course, our privacy and safety of the patient is important. And next. So tips for starting it, make it a part of the nightly routine. Don't skip it. Do it every night. If you're having no soiling, that's when we start thinking about, okay, I might take one night off a week and see how I do. And then I might take some other night off, but never 2 nights in a row off. Multitask when you're doing all this time seating to evacuate. You can watch TV, you can catch up on your social media, you can work, you can read, have at least that one backup person. And then toileting is private, but it's not a secret. You got to let people know I need the time I need to take care of myself. And then being patient and persistent. The results could be really life-changing for a lot of our patients. So we typically start a list of least to most invasive. And so someone sent a question in, and we always start, I think it is, we don't mention it here, but diet is really key. Fruits, veggies, whole grains, water is so important, right? To helping all the fiber work in our systems. But fiber is also a bulking agent. And so we don't always like just fiber. If somebody's having, a lot of diarrhea, they have a faster transit time, they may need a bulking agent like a fiber supplement. But dietary fiber is what our goal is. And then if we're starting medications, oral medications, and other things. So we'll go through a list of these next. So our baby steps start with oral medications, Miralax, lactulose, Senna. All of those things can be used. Senna for some patients really is helpful. It can help them. You give it in the morning, in the afternoon, they come home and they have a bowel movement, before or after dinner. Some people like to give it after dinner and they have one before bed. Some people it's before bed, they have it the next morning. It can really help some people, and other people it does nothing for. So it's really about figuring that out for that patient. They need to give it for at least a couple of weeks to figure out if there is any rhyme or reason to it. Suppositories, again, I think Mary Ellen talked about this. If you put a solid suppository in, but you have no anal sphincter tone, it's not going to stay in. But the digital rectal stimulation could actually be helpful for some patients. So that might be part of it.
Can I just add something too to this? I feel like with adults, they have a tendency to stay here in this baby step land. And we kind of stress, as does the protocol, really moving them on. So if you have a nurse, yourself, an APP, somebody who can check in after they've seen you in clinic, maybe in 2 weeks, a month, kind of short term right after. And if this isn't working, move them on, because adults in particular will stay and they will kind of titrate. Oh, I'm going to do more Miralax. And Miralax is just going to soften the poop. It's not going to help it not come out. If Senna's not working enough, that's not working. You've got to move on to some of these other pieces that I think Joy's going to get into. But making sure they don't just stay here for years, because I think it's a habit.
Which they do. Cone enemas are pretty popular when we start for kids. I don't think they're super helpful for adults. But it's, we left it here just to say it is out there, and typically it is the starter enema, but I think it's really challenging to give to yourself because of the way that you have to hold it in. Most people have to use two hands. And if you don't have good mobility or aren't able to steady yourself on the toilet, then that's really a problem. So we'll keep moving on to the next, but it is out there and some people are using them as adults. Transanal irrigations, I'm going to let Mary Ellen talk about them because she has some exciting news as well to share about them.
Yeah, so transanal irrigations, when we talk about TAI or transanal irrigation, currently in the US, we're really just talking about the Peristeen Plus and the Navina device, Navina or Navina Smart. Those are the only two that currently are technically transanal irrigation. And I think for adults, that's kind of the new starter, because we're not starting with cone enemas anymore. So this is kind of your starter per rectum, kind of bigger enema or not enema, transanal irrigation that we are doing. There is quite a distinction between the words enema and transanal irrigation that we're trying to be aware of. But these devices, if you're not familiar with them, there's a ton of YouTube videos. You can go to the product websites, etc. But you're essentially taking what's a very small Foley balloon. They are hydrophilic, so nice and soft. They insert it into their rectum. And then using the little pump devices, you are pumping air into that balloon to essentially try to kind of contour the rectum, or at least create a seal above the external anal sphincter. So with that, you can now hopefully go hands-free. There are many people who cannot go hands-free ever, or need to wait several months before they can go hands-free, just because of the amount of pressure that is in their rectum because of the size of their rectum, which ideally will come down with continued use. So again, that's all about setting that expectation. You may have to hold this catheter in, and hopefully in time you won't have to. But the catheter stays in or is held in. And then you are using a pump as well to now not just use gravity like a cone, but to use some pressure to pump water and just tap water up above the catheter tip. So it's going into the, rectum, the descending colon, and they've done some studies showing that this can get up to like the splenic flexure. And it's at that point where it really triggers the contraction of an automatic kind of peristalsis just from that water hitting that. I think it's the mast cells there, and somebody in GI can correct me. And really triggers a peristaltic reaction. So at that point, they can just deflate the balloon, pull out the catheter. There's no dwell time where they have to hold the water in. Just once the prescribed amount of water is in, they deflate the balloon, and they ideally pass their bowels, fecal matter into the toilet thereafter with the water. We use the same amount of water for this as you would with like a cone enema. It's 10 to 20 milliliters per kilogram, but we don't ever really want to go over that 1 liter mark. Ideally staying 500 to 700. Do you agree, Joy?
I totally agree.
Okay.
I have patients who will do 1,000, and I
It's a
just feel
lot
like
to
all
come
they're
out.
doing is distending their colon,
And it's a lot of water to then pass after. So I find that a lot of our adult patients that I'm seeing have kind of bumped it up on their own. And then they come in and they're like, I'm sitting on the toilet for 2, 3 hours.
Yeah.
And I'm like, well, when are you done passing poop? And they're like, 20 minutes, 30 minutes. But I still have all this like liquidy kind of stuff. And I'm like, it's just the water and it's having a hard time all coming out. So sometimes less is more.
If you do, so sometimes we'll do like a contrast enema on a patient, and even on a KUV, if you do one, you can see a lot of these patients have a really redundant colon. Their descending colon, sigmoid colon is redundant. So my thought is they have these dependent loops of bowel that fluid is just sitting in, and we're waiting for that peristalsis or even getting up and moving for some of that to pass. And so if you overdo your volume, you're going to be sitting there all day waiting. And a lot of families will tell me, oh, I did it before bed, and then in the middle of the night, we had all this fluidy, liquidy stool output because they're using way too much fluid. Let's cut it back and do less. Less is more sometimes.
Yeah. What's nice here is, again, you can do this sitting on a toilet or on a commode. So if someone can transfer, that's really helpful. Additionally, generally, you're not going to use any other additives for this. You're not going to be kind of making concoctions with salt and glycerin and soap and shampoos. Just water is usually sufficient. And
but beware, your patients will add things to it anyway.
Oh, I remember what I was going to add. I feel like when these first came out, I think it was 2015, we
14.
kept a lot of patients on Miralax at the same time, thinking, hey, let's soften their bowels and then evacuate them nightly. And what we found, and this is going to depend a bit on mobility status of your patient in particular, but adding an oral medication to a TAI tends to decrease continence. So I'll say that one more time. Adding oral meds to your TAI, you're going to have more accidents. So almost always, often with adults, you have to do it slowly, right? Change is hard, but slowly try to wean off the medications that they're on and see how they do. It might not be everybody. Somebody might still need a low dose of Miralax for consistency, but that can help. And also,
I have patients on a teaspoon, Mary Ellen. They swear that if they don't have that teaspoon, it's not but
that's fine. Go ahead.
That's okay. But we try to wean them off.
And also, if you find they're taking a long time to evacuate after, some individuals will do, just abdominal massage. So starting at the right, going up and around can help to kind of move everything out, or taking like a bolster pillow or even a stuffed animal, or kidney pillow, putting it on their belly and kind of leaning forward if they can, to the same thing, just kind of almost do an abdominal massage to help expel any residual water. The fun fact we were excited to share is there is a lot of flack that, oh my gosh, I love these products, but I can't use them because of my state. Hopefully this is changing. So we did just get a positive benefit category back in April for Medicare for TAI. So that is for Peristeen Plus and Navina, which means that as of now, currently, you can prescribe to any adult with Medicare a TAI, and it should be fully covered nationally. What's extra exciting is generally once CMS has made this decision for Medicare, it should trickle down. Times are different, so time will tell. But it should trickle down to private insurers and state Medicaid. So there are a lot of state Medicaids that currently cover this, but there are also some that still don't. So we're hoping it'll be more universal in time, but very exciting that at least patients on Medicare, as of now, write them a script, send it in. They should be able to start getting this now. These are kind of more of our surgical or procedural options for managing the bowel. A lot of them, if you are solely seeing adult patients, they might come to you with these from the pediatric clinics. I think we do these more commonly in peds, especially your Malone antegrade continence enemas, your MACEs, chates and colostomies. I think same, more common in peds, but some adult providers will place those. But this is, as you all know, just kind of using the appendix or some other part of the bowel to basically create a channel that you can catheterize to instill an enema in an antegrade fashion, so from the top down. We have information in the protocol that goes a little bit more in depth with this, also goes into different solutions you may want to try. We are thinking and trying to kind of get some data showing that potentially using smaller volumes for these enemas actually might be better than the continuing to get larger and larger and pushing in more fluid, kind of for a similar reason as we talked about with TAI. But for some of these stoma placements, you could use a small amount of water and then start to add some of those irritants, right? Your glycerin, soap, shampoo, rather than the large volume, because same thing, it just takes so long for so many patients for that volume to actually evacuate that they just spend so much time on the toilet. It becomes just a true quality of life concern.
I also wanted to just kind of throw out there that I work with an adult reconstructive surgeon who will see patients who haven't gotten this, and they're, maybe they're 18 and they're going to be, this is their first visit at CHOP with the adult provider, because he'll see them at CHOP and then see them at Penn. And if they have a considerably thick abdominal wall, he really does encourage them to lose weight and find a way to maintain weight loss, because those channels are only as big as they can be. That's, your appendix is just as long as it is, and it doesn't stretch that much. And the other issue is that the chates or colostomies are now, I think the buttons are now better. The mini aces are better. They come in a lot of variety of sizes, but the chates, they have 2 sizes, I believe, of chate, colostomy. And then there are not that many providers that insert them in the adult world. So we've had to train people at our adult hospital and then find people in other states where our patients come from who actually will do those procedures for them, because the colostomy tubes have to be exchanged, especially the chates. They have a pigtail, so they have to be exchanged probably once a year, but that usually in an IR situation.
Yeah, I was gonna say we don't use a lot of chates, but the few that do, and I think that's as universal, chates generally are changed by interventional radiology. The cecostomies, now that we have the mini ACE buttons, those are distributed by AMT Medical, I believe still. That's the company. And then the DME is going to be, dependent on who you have in your state. But we have found it's actually kind of hard to find DME that carries it. But what's nice is you can train a patient or a caregiver to exchange that themselves at home. So we usually have somebody come in and we exchange it with them once in clinic and have them kind of do it in front of us. And then from then on, we just ship it to their home. So that can be a nice option for an adult just to kind of have to come to clinic less, and that they can change a mini ACE button themselves. You want to take this one, Joy?
Sure. So there are some complications with bowel programs, and I think it's really important to know that. It's important that if someone's never had a bowel program before, that they do need somebody nearby in case any of these things would happen. If they can consistently do a bowel program without having any complications, then I think, they could technically do it independently without anybody available. But I think it's important just to assess for this. So things like defecation syncope or a vagal response, you can have nausea, dizziness, sweating, low blood pressure, fainting. And I've had little children who have gone through this at times, and some of my adult patients as well. It's often caused by what looks like, if this patient's really backed up, they're dehydrated, they're straining, or they have cramping, or they're in pain. Those are the reasons for those things happening. And so it's really managed by preventing constipation, having a good bowel program, and then for some people, gripping their hands, a ball, or grasping hands together and squeezing tightly is helpful. Patients who have autonomic dysreflexia, they typically know who they are because it doesn't just happen with this. If their bladder's full, they might have a problem. So the headache, sweating, high blood pressure, flushing of their skin, a stuffy nose, goosebumps, bradycardia. It's usually seen in spinal cord injuries, T6 and above. So some of the thoracic spina bifida kids can experience this, or adults, I should say. I'm sorry. And it can really, again, be due to constipation, impaction, bowel pain, and hemorrhoids. And this is a medical emergency. This happens sometimes in our clinic on the urodynamics table, when we're filling the bladder sometimes too. And then rectal prolapse is really when, this is typically due to a weak anal sphincter, which we know most of our patients have, and rectal muscles, but constipation, where they've got so much pressure in that lower, sigmoid rectal vault that it's just, the tissue is just coming out. It can be gently put back in with a lubricated, glove finger. And then sometimes it does require surgery, or they do other procedures too, injection procedures and things like that. So, but that would be a general surgeon who would need to see them if that's like a chronic problem, because I think it's very uncomfortable for some patients.
This
Mariel?
is just kind of hitting on information we gathered from a registry, information we gathered from registry data. There we go. That was talking about independence rates with kind of the common interventions that we've been going over. And we did find, especially in adults, that, sure, suppositories and sitting on the toilet are going to be a little bit more independent. But when we talk about things that we think are also going to achieve continence, antegrade enemas, so your ACE, MACE, CHATES, colostomies, as well as this says Peristeen needs to be updated to TAI because now we have Navina. But your transanal irrigation products and then suppositories are sort of your top three most independent rated items for adults with spina bifida. And I will say, even with this, I think for the antegrade enemas, which was the highest rated for independence, it was still only about 64 or 68% of the individuals were able to be independent. So I think that's a really important thing to be very honest with your patients about. And some of that just has to do with body habitus, right? If it's difficult to get to that area on their body, their dexterity, and of course, ability to transfer or stability on a toilet. So there are some predictors that you could probably figure out just in clinic, but even so, just letting them know that none of these have 100% independence rate.
And I'll put a plug in for occupational therapists who that's their job to help people figure these things out. And so if if your patient's struggling with independence, I would say not all of the OTs are going to be familiar with this, but if you can find someone that you can train and help them understand what these things are that these patients are dealing with, they'll grab it and run with it.
This really, you can kind of tell we have these little appendix things happening on the side. They're not exclusive. They're just like to tease you a little screenshot. These are directly from the Lifespan Bowel Management Protocol, so you can go and read the whole thing, or print it out, or whatever you want, frame it. It goes into more in depth than we're hitting here. So obviously adults, many of these individuals are going to become pregnant or want to become pregnant, and they have questions about how that's going to affect their bowels, as they should. So we are pretty frank that we know that pregnancy is likely going to increase their constipation. So that means we may have to be more proactive, either in the frequency that we're using, like a per rectum or a ACE, colostomy kind of intervention, or we may have to actually add some sort of Miralax or some sort of stool softener to help them out. We also know that they tend to have an increased amount of skin breakdown at any colostomy sites or MACE sites. It also can be more difficult to reach those sites, just bodies change, bellies get in the way, they get bigger. So reaching those channels and utilizing those channels can become a lot more difficult. So sometimes we have to come up with kind of a new temporary intervention. Also, if somebody plans to have a cesarean section for their delivery, it's important that their urologist knows that, especially if they have had abdominal surgery, because generally they want to be there. They want to be in that room to kind of protect what they have created. So if that's a MACE, a Mitrofanov, an augment, we'll kind of broaden it. Generally, you're going to have your obstetrician, but you're also going to have your urologist there at delivery. So making sure that our patients know, please let us know if and when you become pregnant, so you can be part of those conversations.
So colostomies, in the past, I would say most of us would think that if somebody, we ended up, just going to a colostomy because we just could not achieve bowel continence, that this would be a failure on our part as, providers. But what we're learning is that patients actually really love a colostomy. There is no timed seating. They're not spending time on the toilet. They're not making a mess in the bathroom with water everywhere. They have complete control over their bowel. They know when to empty their bag. They're not having soiling. It is actually a nice option for some people that, if they don't have the ability to be independent to do some of these other options. It's not our first choice. And it shouldn't be for anybody, but if for some of our patients who really can't do this independently, who want to have a little more freedom, or who can't do this for themselves and don't have somebody who can help them do all this, this is a good option.
Yeah, a lot of people will say, why didn't I do that earlier? So having those conversations and letting it be in the mix is so important.
So we had some questions come to us in advance. So Marilyn, do you want to talk about these two?
Sure. So the first question that somebody had submitted ahead of time, how do you counsel patients to adjust their bowel regimens around the time of their menses? So we start this conversation with 7, 8, 9, 10, 11-year-olds, right? Whenever their menstrual cycles hit. And generally I have them keep track for like a month if they can, and just kind of like, hey, especially if they have a regular cycle, can you just kind of let me know what's happening? Are you getting more constipated and then you're having diarrhea or like fecal incontinence, or are you skipping straight to fecal incontinence? Kind of what is the symptom? But 9 times out of 10, we end up saying that the individual needs to up their bowel program, or their frequency of their bowel program around the time of their period. So a lot of the girls that I care for, they'll maybe be on a transanal irrigation every other day, but around the time of their period, they have to do it daily. So a little bit of pre-work from the patient with the diary can help, but most of the time it's just going to be, you need to do a little bit more.
And using an app to keep track of their periods is helpful too.
For all of us, honestly.
For everybody. Yeah.
Then also adding to this, kind of what age do you start to counsel about anal plugs? And I always joke that I have a plug for anal plugs, but anal plugs, as we all know, are technically not FDA approved in the United States. Hopefully we will change that. But they are approved in other countries, such as our neighbor in Canada and across the pond in Europe. You can sometimes find them still, although becoming more difficult to find them as one of the main producers, Coloplast, no longer produces them. So I forgot there's a new name of a new one out there. Maybe it'll come to you, Joy. There's some patient actually told us about recently. Yeah, we'll think of it. If we tell you, we'll let you know. But if you Google safely and see if you can find some, you can sometimes find these on eBay or on a medical supply, and you just need to make sure that they're obviously okay. But I wish they were more allowed in the US because I think they're awesome. They're really good if somebody suffers from fecal incontinence and they want to go swimming, they want to go to work, they want to have a regular day, go to school, whatever it is, because it acts like a tampon essentially in the rectum to hold the bowel in. And then when you're home, you just pull it out. So we will be coming at you all one day to help us fight this with CMS and FDA. So we should get the name of this person and then you can join our fight. Oh, there it is. There's my anal plug. So just more information there, but same thing.
Whole appendix. Yeah.
Whole appendix on it. Although unfortunately we'll probably have to delete some of them since some of the companies have changed.
So I think, do you think natural first bowel management? I think natural first bowel management with good, fiber, fluids, all those things, knowing what your triggers are for, greasy foods that cause diarrhea, all those things are really valuable, but they're often just not enough for a patient with spina bifida. They need, or neurogenic bowel dysfunction, they need a way to empty that colon on a regular basis so that they don't have soiling. So I think we always want to support natural first bowel management, but it's typically not enough for our patients.
Yeah, I think we ended up phrasing it even in the protocol as, the water, the fiber, the good diet is bowel health. That is taking care of your gut and bowel health, your microbiome, all of that stuff. It is not a bowel program. So sometimes phrasing that to the patients may be helpful too. Like, yes, please do that for your own bowel health, but we need a program to get you continent or whatnot.
So what are the impacts of bowel management routines, such as a MACE, on weight loss medications, surgeries, or other solutions, or vice versa? I would say that there's probably not, having those surgeries doesn't impact the GLP, but the GLPs can impact, so let's talk a little, can we look at the next slide? So I said a little bit, if you're having an ACE, a MACE, or a colostomy, and you have a very thick abdominal wall, some surgeons are going to say, can't do this surgery. It's not going to work for you because unless you have the longest appendix, and some kids have really crazy long appendix, they really do, but it's only so long. And if you just continue to, be sedentary and the abdominal wall becomes thicker over time, it's more difficult to pass a catheter. As much stretches on it, you may get a very deep pulled in type of a MACE ostomy site. And that can be really, really challenging. So I was really grateful. Judy sent me this, actually Juanita sent me this really nice presentation that was done at our clinical care meeting about GLP-1s. And I have a surgeon that talks about it all the time because he's like, we need to get some of these kids on GLP-1s because we really can't do surgery on these kids who have, who are really heavy. So just a little background, they were discovered in 1981, originally used for diabetes management. The first prescription was in 2005 with twice a day injections. 2007, it became a single daily injection. And then in 2014, they really noted the weight loss benefits. From 2019 till now, we all know, we've seen every commercial for this explosion of drugs that have been available, right? So it's released in the ileum in response to glucose. So it slows GI motility. It decreases hunger, but it also is, you might have a little gastroparesis from it. Some different, feeling uncomfortable. It does have an effect on the brain as well, and your feelings of hunger and and it has side effects, nausea, decreased appetite. Obviously, you hope for that. Reflux, constipation. We're already dealing with constipation. abdominal pain, sorry, not PN, and pancreatitis or loss of lean muscle mass are are some of the severe side effects. And then the next slide talks about the response to GLP-1. So 17.8% of people are non-responders. They have 5% total body weight loss or less. 48% have moderate responders, and 5 to 10%, and 38% are hyper responders. So they have greater than 15% of body weight loss. So the considerations for patients, certainly if they need a surgical intervention, they are overweight, they have obstructive sleep apnea, they're having any kind of pain in their lower extremities, like severe, from knee bony pain, not from other issues from their back. Cardiac disease, kidney disease, it will, the progression of all these will be decreased if they are on these medications. So thinking about any of that is really important. So it's not just about the bowel program, but thinking about the big picture. How will this benefit this patient in the big picture? I think is really critical. And I think it can be very beneficial. And I think we need to consider a little bit more about using them. But it can cause constipation. I don't have anyone in my practice who's on one, so I have no, personal experience with it. But, I can imagine that the constipation, you might just have to change how you do your irrigations, or you might need to add some type of an irritant so things will move through. We just, I don't have enough experience with it.
Agree. I second that.
Second that. Want to take that one?
Sure. So how and whom to transition from pediatric to adult care for bowel management? Great question. Whoever will take them. Find your resources in your area. So there are, not enough adult clinics. So obviously if there is an adult multidisciplinary spina bifida clinic, head there. We did a survey of spina bifida clinics a couple years back now saying like, hey, who's actually managing the bowels? Because I don't know if you noticed, but Joy and I are actually urology-based people. So it tends to fall on the urology crowd, and that was across the board, across the country. Urology tends to kind of step up and take on the bowels. But I will say adult urologists, I haven't met a single one who would like to do that. Peds, we tend to take them, adult won't. GI, you might be able to find somebody who's willing to take this on, like a standard gastroenterologist or colorectal. But that's hit or miss. A lot of people just aren't trained on neurogenic bowel, especially in spina bifida, and they end up just giving them tons of Miralax, which isn't going to help. PM1R sometimes can do a wonderful job. It's really just kind of, unfortunately, doing a little shopping and trying to find somebody who is interested or wants to learn, and trying to train them up. So not a great straightforward answer.
I think, a lot of programs are realizing that this is a big deficit in their program. And so I think many programs are trying to somehow bridge that gap. I know in our world, we have identified both a GI and a colorectal surgeon and the Penn system who have verbalized interest in this area. But one of the big issues we have right now is that their insurances don't always translate to be able to go be seen at that hospital. So these are the things. So we brought in an adult urologist to our practice, and we're hoping that we can do that with these other practices too.
And also we're doing some studies now looking kind of longitudinally, like, hey, if we just do a great job in the adolescent years and get these people on awesome programs, will it hold? Jury's still out. We looked at the data today, and I'm not smart enough to analyze it without my statistician. So we'll get back to you on that. But I would assume that will help, right? So some of this is going to be, hey, we really just need to start implementing bowel programs younger and more effectively and more forcefully in a way, and hope that it helps. Judy had mentioned in the chat too, of course, you can reach out to the SBA's National Resource Center. They might know your area or the area where this person is moving to and be able to help them find somebody. This is just a general kind of info slide, I think, kind of based on some questions we had that were similar about kind of self-management in the future in adults. With any new program, making sure that they're going to be set up for success. So depending on what kind of executive function kind of disabilities we may be working with as well, kind of working with the individual to really write out the instructions they need, maybe take a video, maybe do a visual, something that's really going to engage them to make sure they're using any new products correctly. Also teaching about where they can get supplies or who to contact to get supplies, right? Because just like with urinary catheters, you got the company, but also the DME company. Making sure that they can reach everything from wherever they're planning on doing their bowel program, especially if they're doing this solo. As Joy already mentioned, PT/OT can be super beneficial. Utilizing technology. So again, any way they can contact you that doesn't involve having to come into clinic can be helpful. And then, of course, really exploring any barriers. If someone comes in and is like, nope, it didn't work, really ask why. And how many times did they try it? Was it one time? We have done, I know both Joy and myself, especially starting in COVID, and we've kept it up, is doing a quick virtual visit if needed and actually seeing the bathroom space. So having them, take their phone, their iPad, whatever it is, and kind of showing you what they're working with really helps you troubleshoot what's going on.
It's unbelievable. I just did one yesterday and it's just amazing. You're like, okay, I see what you're doing wrong there. I see this. Okay, try this, do this differently. And it's just amazing. And parents are like, oh, that actually does work. Thank you.
Yep. We also talked a bit about kind of getting information. So bowel diaries, I think these are vital. If someone wants to start a new program, you need to know what's going on now. So we do have an example in the protocol that you could print out. This is kind of the headings, but just really detailing, ideally at 3 to 5 days minimum, ideally a week or so, about, hey, when are you actually having incontinence? When are you having regular bowel movements? Where? Those sort of things. And of course, if they are on a program that's not working, we want to know what they're doing and when. So just intel for you and for when they come back, so you can really make sure that you're making progress. And this is just some of our favorite accessories that you can find on Amazon that could be really helpful for all ages. But the TableMate TV tray is nice because it's doesn't have too much of a cumbersome bottom, so you can generally fit a wheelchair or commode still there, and this will hang over. A lot of adults like this, even just to lean on when they're trying to expel the stool. But of course, you could use it to keep yourself entertained while you're sitting on the toilet.
Or work.
Or work. That's what I mean. Whatever you need to support yourself. Squatty potty. I think we all know about squatty potty, especially individuals with spina bifida or any kind of lower decreased sensation. Important to make sure that they are supporting their legs and they're not just dangling, because they're going to potentially lose more circulation. So squatty potty is a great option. We often use glycerin in many of these kind of managements, especially, again, the MACEs, ACEs, colostomies, chates, in which case we recommend buying the cheapest on Amazon. But as long as it is USP grade pure glycerin, you can buy it by the gallon. That's going to be your cheapest way. And if you're going to go that route, make sure that you tell them, hey, here's a hint, get a gallon pump. So that way they can just pump 1 pump, 2 pumps, whatever the measurement is, because I don't know if you've ever tried, but pouring glycerin is really messy. So invest in a $1.50 pump and you can transfer it from gallon to gallon. Same with Castile soap, another common irritant we'll utilize. We usually just recommend a pure Castile soap. This is just a little teaser again about the protocol itself. You can go, the appendices is really where the meat of all the good stuff is. This is just a list of the titles of all of the appendices we've created. So there's a lot of really good information in there, including big sections about like different enemas, different concoctions. What's the better word?
Medications, yeah.
Thank you. What you might put in an enema or whatnot. So some guidance on that, as well as kind of just troubleshooting some things, especially some of the enema systems.
And that's
There's
it.
that. I think we had a couple questions come through that Juanita sent us. This one came to Juanita, I believe. How do young people with no perennial sensation, perineal sensation manage to undertake anal irrigation without assistance? Is there a system that is better than TNI to enable independent management?
So you mean how do they find where to put it because they don't have sensation? We teach them a finger, just finding the hole. First of all, is really important. If it's a glove finger, that's okay too. And I always tell families when parents tell me that kids are having pain, or even older kids and adults, my young adults, they probably don't have the catheter in far enough if they're not putting it in all the way and they're inflating the balloon in the sphincter complex. That's going to be uncomfortable for a lot of our patients. So it's just about, one of my occupational therapists says, do you use a mirror to put your earrings in? Do you, for people, who use tampons, do you use a mirror for that? No. Do you use a mirror for your catheters? Most of our patients don't. It's about finding the right place to put it. And most kids can do that really well.
Yeah, and I will say the catheters for the TAI devices, kind of, and I probably can't tell on my pen, but has kind of these ridges. So they do have ridges on there, and it's flatter, like a little pyramid, so that the person can just feel where they should put their fingers, and then you go until your fingers can feel your butt. So they did try to think about that in that design, so that if you can't feel the sensation internally or on your bottom, your hand can do that for you. So
Joy,
hopefully that
sorry, I muted you. You have to unmute, Joy.
Here's this catheter. It's actually semi-rigid. I say it's really bendable, but it's at the tip, it's rigid, and it has holes on both sides, but there are these ridges here that are the balloon. Is that what you're talking about?
hopefully. I don't know who it came from.
And they have to get it in all the way because this is the room for the sphincter complex here. They have to get it, the balloon area above it. Any more questions?
There was one just about what question would you ask to determine if a provider would be willing to see adults with neurogenic bowel and had the adequate experience? Yeah, I'd want to interview them. No, I don't know. I think you would want to ask if they've cared for individuals with neurogenic bowel or spina bifida in the past. And if not, maybe bring them the protocol and kind of, the protocol was designed originally. Our mentality on it was this is for providers who aren't used to treating neurogenic bowel and want to or are willing to do so, and it gives them a starting point. So I think if someone's willing to take the time to look at that, that might be a provider who's willing to put the effort in.
Thank you.
That's all the
Joy.
questions.
Thank you, Mary Ellen, once again for all this valuable information that is needed by so many in our community. Please, those of you who have been on the call, complete the evaluations and let us know how we can be of more help in this area or other areas that would be of interest to you in the future. So with that, we'll say good night, good afternoon, wherever you are.
Thank you.